Hello everyone. Today we have Dr. Sakshi Bhatia, who has just given the exams and she is just awaiting for her counseling, and now she wants to share something about the topic that is the IV fluids. So coming on to Sakshi, yeah, you can go ahead.
Yeah, hi everyone. So the motive of today's session on presenting IV fluids is basically to give it most knowledge at hand, and especially which will be most useful to all the interns who are right now going to their duties every day and working in the wards. But one thing which is lacking behind is that we keep the least of knowledge of the ongoing protocols and the management of patients in the ward. So the motto of today's session is to give the knowledge about IV fluids and their management. So yeah, I'll present my screen. Start.
Yeah, go
Okay.
ahead.
Okay. So IV infusion fluids are classified into four types. So we have crystalloids, colloids, blood, which includes whole blood components, and purified blood fractions. And then we have other fluids, which includes nutrients and antimicrobial agents. So first we'll understand is what are crystalloids and what are colloids. So crystalloids are basically the solutions which have
Mm.
solutes with small molecular weight, and they can pass easily through semi-permeable membrane. And crystalloids include non-electrolytes like dextrose, fructose, and mannitol. And with electrolytes, we have saline, and then other electrolyte solutions, which we will see further in the session. Next are colloids. So by colloids, what do we mean by colloids? So colloids are solutions with solutes with which are large molecular weight, and they don't pass easily through semi-permeable membrane, for example, plasma expanders. Okay. So IV fluids are basically they are present in the form of glass containers or stiff plastic containers or bottles. But nowadays in the market, you can see that the bottles are not used for IV fluids, but they can be used for peritoneal dialysis solutions or bladder irrigation solutions or 20% salines or anticoagulant solutions for blood donation. So first we'll start with crystalloids, and in crystalloids we have dextrose. So dextrose, the 5% dextrose. So one bottle of 500 ml, it contains 25 grams of dextrose, which gives approximately 85 calories. So if we are giving 3 liters of 5% dextrose to any patient, which is given on usually as a daily management, barely it provides calories to avoid starvation ketosis in the patient. So now the next question comes: is dextrose used for intravascular volume expansion? So the answer is no, because it goes out of the circulation to interstitial and cellular components. Here I want to highlight the most important point while managing a patient who is on who is given dextrose. Si- since it stimulates insulin, sorry, pancreas, which further release insulin, so it can cause hypoglycemia and hypokalemia in the patient the moment we give dextrose. Second point is dextrose cannot be mixed with blood as it can cause hemolysis. So now what are the indications of dextrose? Since
Mm.
it's an electrolyte free water, that is, it is isotonic in nature. So it when other electrolytes have been replenished by IV fluid, water requirement still remains high. In that case, we have to give dextrose to a patient. Next is it is used in the prevention and treatment of dehydration. Now, in dehydration, what happens? There is excessive water loss, which can lead to hypernatremia in the body, and there we can use dextrose to prevent hypernatremia. And other uses, it can be used as a vehicle for IV drug infusion, and also as we have seen that it can be used for the treatment and prevention of starvation ketosis. But there are certain contraindications where we can't give dextrose to a patient who's in hypovolemic shock or cerebral edema or in water intoxication. Now, there is something called inverted sugar solution or fructose, which is not commonly used, but just for a knowledge point of view, the viewers can listen to this. So, it is an equimolar solution of half dextrose and half fructose, and it is used to treat nausea and vomiting as well as in liver disease patients, as it prevents glycogen depletion and it provides glucose and thus helps in exerting a protein sparing effect.
So
So
basically,
after
I just want
dextrose,
to have a
we
minute. Basically, I just want to ask you here. So you cannot give DNS in any person who comes with a shock. Well, it is not an initial management, I guess.
so in DNS,
Typically, it's
D
a maintenance
sorry, can you
fluid, not
repeat
an
this?
initial management.
Yeah. So there, it's a maintenance fluid, and yeah. So next is normal saline, and the next question it's is it neutral? So yes, it is a neutral solution, but it doesn't mean that in body it is not at the neutral pH. It is acidic to body, and the further points are it doesn't contain any calories, and sodium when given alone can worsen and complicate hypokalemia, and it can be used in mild metabolic alkalosis. Since it is mildly acidic, so we can use it in mild metabolic alkalosis. And it can also be, it should be used carefully in post-operative period in the patient. So the question is it saline is an intravascular volume expander or not? So yes, it causes intravascular volume expansion by 25% of its infused volume. So let us see the constituents of 0.9% NaCl, which includes 154 millimole per liter of sodium, 154 millimole per liter of fluoride. So both sodium and fluoride has the ratio 1 is to 1. And there is no potassium and bicarbonate. So the overall osmolarity is 308 milliosmol per liter. So saline is so we have hypertonic saline and hypotonic saline. Hypertonic saline is it comes up to concentration of 5%, and mostly it is used in hyponatremia of water intoxication. But when it comes to the case of 20% hypertonic saline, it cannot be used as an IV solution, but it can be used as a sclerosant or to induce abortion in certain cases. Next, we have 0.45% or 0.2% hypotonic saline, which can be used in children and in euvolemic and hypovolemic hypernatremia. For example, in cases of excessive sweating. Next is we have isotonic saline. So the major indications are since it can maintain the osmolarity of extracellular fluid, so it is used for water and salt depletion. And also it is mildly acidic to body, so it can be given in mild cases of metabolic alkalosis, but not in cases of severe metabolic alkalosis. And it is avoided, sorry, then also can be used as a vehicle for drugs, and it is given in hypovolemic shock patients also. So there are certain contraindications of using isotonic saline in cases of hypertension, renal disease patients, liver cirrhosis patients, congestive heart failure patients, young and elderly patients, and severe acidosis. Okay. So next is we have dextrose and saline, which we all have seen as a 5% DNS solution, which is hypertonic, and it is not physiological to the body fluid volume. And it is acidic, so we can use it in alkalosis, but it is better than normal saline. Now, why it is better than normal saline? Because it gives additional calories while we are giving DNS to the patients. So our patient doesn't survive uh, don't doesn't land to starvation ketosis. And next is also we have something called 5% dextrose with 0.2% saline, which is closer to the physiological volumes, and it is good for pediatric use. So next we have ringers. So ringers is mostly closer to the extracellular fluid composition, and it is rich in sodium, alkaline in nature, most versatile fluid to be used, and but it can't fulfill the maintenance of requirements of calcium and potassium. So ringers are two types. One is ringers lactate, which is Hartmann solution. So here I want to highlight a specific point which has been asked in INI set as a previous year question, where they gave the composition of a solution and they asked the and it was asked to identify the type of solution. So the ringers lactate, it contains 130 millimole of sodium, 109 millimole per liter of chloride, 4 millimole per liter of potassium, and 28 is the bicarbonate. So but this ringer lactate cannot be used in patients with anoxia or liver disorders. So what the question comes now, what can we use? So the alternative option to this is for liver disorder patient is ringer's acetate. Next, we have maintenance fluids and replacement fluids. So, maintenance fluids are the fluids which are low on sodium but they are rich in potassium. So, they replace the fluid loss from lungs, skin, urine, or feces. So, the examples of maintenance fluids are isolate M and isolate P. Next, we have replacement fluids which are rich in sodium and also they have some amount of potassium in them, and we can use them in cases of vomiting, diarrhea, or intestinal edema or gastric drainage. For example, we have normal saline, DNS, ringer lactate, and isolate E as replacement fluids. Then also we have special fluids which can be given in hypoglycemia and hypokalemia patients or metabolic acidosis or alkalosis cases like 25% dextrose or isolate G or mannitol or potassium chloride. So now I would like to summarize till now whatever fluids we have seen. So the most physiological fluid is ringer lactate. Fluid which are rich in sodium are normal saline, DNS, isolate E, and ringer. Then the next is fluids which are rich in chloride are normal saline, DNS, and isolate G. Fluids which are rich in potassium are isolate R, M, and G. Now, alkaline solution fluids are ringers, isolate E, P, and M, and acidic solutions are normal saline, DNS, and isolate G. So, there are fluids which are to be used cautiously in renal failure patients like ringer lactate, isolate G, M, P, and E, and fluids to be avoided in liver failure patients are ringer lactate, isolate G. Then normal saline and ringer lactate are glucose-free solution. Dextrose is a sodium-free solution. Sodium, sorry, DNS, dextrose, and normal saline are potassium-free solution. And solutions like isolate E and isolate P contain magnesium. So, af- after we are done with the different type of crystalloids, now we will learn how to calculate the rate of IV fluid. So, 1 ml of fluid it contains 15 drops. So, there are two methods by which we can calculate the rate of IV fluids. One is when we have to calculate the fluid requirement for per day, and one is for per hour. So there is something called rule of 10 and rule of 4. So rule of 10 is used for per day drip adjustment and rule of 4 is used for per hour adjustment. So suppose, so the formula to calculate is IV fluids in liter per 24 hours is multiplied by 10. It gives the rate, drop rate per minute. Suppose we have to give 3 liters fluid in 24 hours to any patient. So we'll multiply 3 by 10. That gives us 30 drops per minute of that solution. Next is rule of 4. So rule of 4 is volume in milliliter per hour is divided by 4, which gives us drop rate per minute. Suppose we have to give 60 milliliter per hour, so it gives us 15 drops per minute. Okay, so now when we are done with crystalloids and calculation of the fluid, next we move on to the other category of fluids, that is colloids. Okay. So first we have plasma expanders. So plasma expanders, as the name suggests, that they expand the blood volume by 50% of the infused volume, and electrolyte. They are electrolyte. On the other hand, the electrolyte solutions which expands the volume by 25%. So, but the disadvantage is that since they are high molecular weight, so that leads to high viscosity of the fluid, and this can result in damage to microcirculation. So, what are the contraindications of plasma expanders? So, the contraindications are if the patient is of any known hypersensitivity, or the bleeding disorders like thrombocytopenia or hypofibrinogenemia, or there is a case of severe dehydration, there we can't use plasma expanders. Next, we have albumin. So, albumin is a physiological plasma protein, as we all know, which maintains plasma osmotic pressure, and it binds and transports low molecular weight substances like bilirubin and hormone. So, the indications of using albumin, it corrects hyponatremia, and the adverse effects are it can lead to nausea, vomiting, febrile reactions, or allergic reactions. But there are special precautions with albumin, which should not be used for parenteral nutrition. Next example of colloids is dextran, which comes in the form of dextran 40, dextran 70, and dextran 150. So, what are dextrans? Dextrans are glucose molecules which are produced by bacteria, which replace 35% of the total blood volume. So, what are the indications? Now, any patient who is coming with deep venous thrombosis or is a case of post-op or post-traumatic thromboembolism, there we can give dextran. Now, the dextran, low molecular weight dextran 40, it helps in improving blood flow and microcirculation in case of gangrene patients. But there are side effects of dextran also. So, side effects are like acute renal failure. It can cause hypersensitivity reactions, and it can interfere with the blood grouping cross matching. So next we have HemSL, which is a gelatin polymer. So the molecular weight is it ranges between 30 to 35,000, and it can replace up to 40% of blood volume. So the advantage of using HemSL is it doesn't interfere with coagulation and blood grouping. And so since HemSL does not have any preservatives, so it has to be, the solution has to be clean before use. And also, it doesn't contain calcium, so it cannot be mixed with citrated blood. Then, side effects of HemSL are again hypersensitivity reactions and bronchospasm, or it can lead to hypertension in patients. Next, we have hetastarch and pentastarch. So, hetastarch is a synthetic colloid which is 6% solution in isotonic saline, and it contains more than 95% esterified amylopectin. And the advantage of using hetastarch is non-antigenic, is least expensive, and doesn't interfere with blood grouping and cross-matching. And now the newer modality of hetastat is the newer low molecular weight derivative, pentastat, which comes in the form of 3%, 6%, 10% solutions. And it has high colloidal osmotic pressure and it is more effective. So usually when we give 10% solution to any patient, it increases the volume by 1.5 times of the infused volume. So last is we have other fluids, that is IV proteins and IV lipids. Uh, and IV proteins includes amino acid, that is 8 gram amino acid per 100 ml, which come in the brand name of amino drip, aminoplasma, alamine, aminovan, hermin, and vamin. And also we have IV lipids, 10% IV lipids and 20% IV lipids. Next we come to mannitol. So mannitol,
So before that, I want to ask one thing. Matlab, suppose a patient
yeah,
comes to you with a shock. So what will you give, a crystalloid or a colloid? What is your preference of?
okay. So in case of hemorrhagic shock, usually crystalloids are preferred. As I mentioned that colloids, most of the colloids we have seen that they can cause allergic reactions and hypersensitivity reactions to patients. So it's better to, uh, and also we have seen that most crystalloids are used as the replacement fluids. So in case of hemorrhagic shock, it's better to give crystalloids than colloid.
Okay, one more thing, it is macromolecular. Basically, the size of the molecules are very large than the crystalloids, which will again lead to kidney injury or kidney damage. So in that case, also
Yeah,
crystalloids are more preferred than colloids. Yeah, you can go ahead.
yeah.
Mannitol. Yeah.
Okay. So mannitol, as we all have studied in the diuretic chapters of pharma, uh, it is an osmotic diuretic, which is a six-carbon sugar derivative from reduction of glucose metabolically, and it is virtually inert. So the three major uses of mannitol are acute congestive glaucoma, dialysis disequilibrium syndrome, and cerebral edema. And the contraindications are it can't be given to pulmonary edema patients, or it should be used cautiously in cases of intracranial hematomas and renal shutdown.
It was
Yeah.
it. So I just wanted to ask some questions in that regarding. So what will be the fluid of choice in case of vomiting? What will?
So in case of vomiting, as we all know that
Mhm.
there is loss of H plus from the body, which leads to metabolic alkalosis. So if we'll give iron, that will lead to increase alkalosis. So it's better to use NS, normal saline there.
Yeah. Basically, RL has lactate in that, which will again leads to increase in bicarbonate and again metabolic alkalosis. So yeah, NS is preferred in that case. And again coming to suppose if you have a patient coming with diarrhea, so what will you give? RL or NS in case of diarrhea?
Okay. So in case of diarrhea, to compensate the complete electrolyte losses, it's better to give ringalactate in that case, which is a composition of all the
All the
electrolytes.
electrolytes. And in case of suppose patient comes to you with a DKA, diabetic ketoacidosis, in that case, what will be your fluid of choice?
Okay. So in case of diabetic ketoacidosis, since our patient is already in the state of starvation ketosis, so normal saline has a property that it doesn't lead our patient into starvation ketosis. So the fluid of choice will be normal saline.
Basically, it will increase the acidosis if you give RL in that case.
Hmm.
Then moving ahead, suppose a patient comes to in the emergency with any trauma and it develops a shock. So what will be your management basically? Suppose
Okay.
it's a
So
hemorrhagic, it's bleeding from somewhere, external bleeding is there. So how will you manage in that case?
yeah. So according to the trauma protocols, first we have to manage ABC, that is airway, breathing, and circulation. And in that, first we have to manage the circulation part. Okay. So the preferred fluids will be the IV fluids first, but not in the bolus form. It should be given slowly and not in the rush form. So that is to maintain the permissible blood pressure in the patient. And next, we have to manage the trauma triad. So we have to prevent the dilutional coagulopathy. And after we are done with the IV fluids, giving IV fluids to the patient, we have to give the whole blood and colloids and RBC in the ratio of 1 is to 1. Then, to prevent excessive bleeding, we have to give tranexamic acid.
So here's the next question. So if a patient comes to you with a hemorrhagic shock, that is, suppose the patient has a trauma and he has profuse bleeding. So you will start with, as you said, steroids, you will start with steroids. So when will you give blood in that case? So what is the time period of you giving blood in that case?
Okay, so immediately as the patient comes to the casualty, first we have to send his blood for cross matching. Immediately we have to give the blood.
Okay. If the patient is unstable, then will you do a full operation or you just control it and come out of it?
So in that case, we have to take the patient for exploratory laparotomy. If it's a case of internal bleeding, to
But in
yeah,
that case, suppose if the patient is not stable in that case, you have to just go do the absolute laparotomy and just control the bleeding and come out. You cannot do a definitive procedure
hmm,
like colostomy or ileostomy, something like that. That is what is called as damage control program or resuscitation. That is it.
resuscitation.
Yeah.
Uh,
And one more thing, what is trauma-induced coagulopathy? Any idea about it? Trauma-induced coagulopathy.
Trauma-induced coagulopathy. So basically, trauma-induced coagulopathy results as a when IV fluids are given at
Uh,
a fast rate and the bolus form that can lead to coagulation and uh,
Dilutional coagulopathy. So it will lead to
yeah,
dilutional
dilution
coagulopathy.
coagulopathy.
And again, the bleeding won't stop, and then again it will go to the shock, and then ultimately the patient will die because of overfluid, overgiving of the fluids. Okay,
Hmm.
that's it. So thank you so much for joining.
Yeah.